Hi, everybody. It's Shelley with 50 Up Health and Beauty, and welcome to the first episode of my expert series. Now, today we're going to talk about ptosis. Now, I started to develop ptosis about 8 years ago, and I had surgery here in the desert, and he lifted my eyelids, but unfortunately, my eyes were no longer symmetrical. So I identified a renowned ocular plastic surgeon in Beverly Hills who corrected the problem. And I am so happy that Dr. Guy Massry has agreed to be on my first episode. Now, to give you a little bit of background about Dr. Massry, is he's a world-renowned ophthalmologist and ocular surgeon. He currently is the co-director of the Thyroid and Orbital Service at Cedars-Sinai Medical Center, Los Angeles. He's a clinical professor at USC Keck School of Medicine, as well as maintaining his private practice in Beverly Hills. Throughout his career, he has received honors and awards for his contribution to ophthalmology patient care and to physician education. He has spoken at literally hundreds of medical conferences, not only in the US, but around the world, as well as publishing numerous research studies, articles, and textbooks. So I'm very happy and excited to introduce you to Dr. Guy Massry. Dr. Massry, I am so happy that you took time out to be here today. And I would like to talk about something that I think many of our viewers probably don't even know what it is.
Right.
But talk about ptosis.
Yeah.
And I know there's two different kinds. You can be born with it and be congenital, or it can be acquired. So since I'm looking at people over 50, I would think we're going to focus in on the acquired part today.
First of all, it's my honor. And second of all, there are actually many kinds of ptosis, and I might worthwhile starting with a brief overview of that, and then I'll kind of elaborate on about it, and because I think it's a lot of useful information. Ptosis comes from the Greek word fall or falling, and you can have ptosis of anything. This happens to be eyelid ptosis. Eyelid ptosis is very different than skin hanging over the lid or the brow drooping, which can mechanically weigh down the lid. Ptosis is when the muscle that opens the eye, as I look up and down, becomes attenuated or weak or detaches, and the actual eyelid falls. And it can fall to the point where it actually covers the pupil and obstructs vision. So that's really what ptosis is. Now, general eyelid surgery is called blepharoplasty, and that's when you remove skin, muscle, or fat, variable degrees of skin, muscle, or fat. It can be done as a functional procedure to improve vision, or it can be done as a cosmetic procedure, and that's what people think eyelid surgery is. Ptosis surgery has nothing to do with removing skin. It has to do with reattaching and tightening the muscle so that the eye is open. It could be done in conjunction with the blepharoplasty or a brow lift, or as an isolated procedure. As far as types of ptosis, someone can be born with it. That's called congenital ptosis. Typically, congenital ptosis is a dystrophy, like muscular dystrophy, of the muscle that opens the eye. There are two muscles that open the eye. One is under voluntary control. It's called the levator muscle. It elevates, and it's a muscle and a tendon. The other is under involuntary control. It's called an autonomic muscle. I'll give you an example. If you go to Halloween Horror Nights and someone comes up and scares you and goes, boop, takes a chainsaw in the back of your head, and you get scared, you have an epinephrine surge in your body, and that epinephrine stimulates that muscle to open the eyelid. That's called Mueller's muscle. It was named Mueller's muscle. So there's a voluntary control muscle called the levator and an involuntary reflexive muscle that responds to epinephrine called Mueller's muscle. You'll see why that's important in a second. Congenital ptosis is a dystrophy of the levator muscle. Usually the eye is low, ptosis. It doesn't open well because the muscle doesn't work well, and it doesn't close. The eye doesn't close well either, because the muscle is infiltrated with fat and what we call fibrous tissue, which is kind of like scar tissue. So it has very little pliability, so it doesn't open well and doesn't close well. It's a completely different ball game. It's a different way of doing surgery. It's much more complicated and harder to get right, and we're not going to talk about it because it's a very unique situation. Then there are forms of acquired ptosis. The most common form of acquired ptosis is a bit of an unfair name. It's called senile or involutional ptosis because you get it as we get older, but it can happen when you're younger. I don't like the word senile either because of its reference. But basically what happens is the tendon that attaches to the eyelid becomes thinned or detaches and slips back. Mm-hmm. The classic form of this acquired involutional ptosis shows a lower eyelid. The eyelid crease is high. The eyelid could look hollow, but when you look up and down, there's normal movement or excursion of the muscle, as opposed to congenital ptosis where the muscle has a dystrophy and it doesn't move well. And that's why it's easier to repair, because you got a muscle that's not working well, it's hard to repair. Think about two cars. One has 500 horsepower, one has 200 horsepower. Which one's going to drive faster? The 500 horsepower. Congenital ptosis has reduced horsepower. Acquired ptosis doesn't, it's just attached. Other forms of acquired ptosis are mechanical ptosis, like you have a mass that grew on the eyelid and it pushes it down mechanically. Okay. Traumatic ptosis, someone has an injury and it damages the muscle. Neurogenic ptosis, something goes wrong with the nerve that's attached to the eyelid muscle, so the eyelid muscle doesn't work well. These are all different forms, but the most common by far that we see is the acquired form that occurs as we mature. So it's called involutional or senile ptosis, how it's classified, but it could occur in your 20s, 30s, or 40s. Younger people sometimes get it because they're eye rubbers. And some people have surgery where a speculum is placed into the eye and stretches the muscle, and it causes the same thing. So that's what ptosis is. And the common finding is one eyelid is lower than the other. It can obstruct the pupil. It can affect visual function. This can be corrected in two basic ways. I'm talking about acquired ptosis, this common form. One is you can make a cut in the skin, look for the muscle that lifts it, and reattach it. That requires patient cooperation. They need to be awake because you have to have them open and close their eyes to adjust it. Okay. And that is the classic kind of form of repairing ptosis called a levator ptosis repair. It requires a much higher skill set than doing blepharoplasty or brow lifting because you have to adjust both the height of the lid and the curvature or the contour of the lid. And it's really hard to address both. The reason is, one, it's a delicate surgery. Number two, a person's awake. You can't just cut on their lid. Right. So you have to give them a local shot that numbs the lid. And in that numbing agent is also something that stops bleeding called epinephrine. So those two components, the local numbing agent can also numb the movement of the lid, and the epinephrine, as I said, can stimulate the lid to open because of Mueller's muscle, that other muscle. So usually we have to figure out a formula of how to adjust it, and over the years what we figured is we leave it about 1.5 millimeters high, and when all that wears off, it equalizes. That's a general rule.
Okay. Because I would think that's where the artistic part, because I always think with plastic surgeons, there's the technical part, right, which obviously after all your training you have, but there's the artistic part that makes both eyes be equal.
Correct.
And, you know, enhance their look as opposed to take away.
Correct. The other way to correct ptosis is to operate on that other muscle, the fight or flight muscle, when you get scared and epinephrine surges. Much easier, done very commonly in certain parts of the country, less commonly in others. It's a geographic thing, and I'll tell you why. If you practice in California, especially Los Angeles, people are so aesthetically oriented, they want a lid that has a perfect curvature, not just height. If you put epinephrine drops in the eyes and the eyelid comes up, that it responds to it, you can do the surgery from inside by resecting the inside muscle. That requires no cooperation. Patient doesn't have to be awake. You have to have them open and close their eyes. It's based on a preset algorithm of how much muscle to resect. And it's a much easier surgery. Now that general plastic surgeons, facial plastic surgeons, ocular plastic surgeons do. The other surgery from the outside is so much more technically challenging. Usually just eye specialists do it. There are places in the United States where people don't do the inside the eyelid surgery because they were traditionalists and trained the other way. But if you are cosmetically oriented, I'd suggest you do it from the inside because height comes up and contour is the same. If you're someone who's worried about visual function, I mean, the opening of the eyelid so you can see better, if you do it from the outside, you can correct a larger degree of ptosis, but you may have some asymmetry in terms of the curvature of the lid. So it depends where you are, what you're looking for. Most of the insurance parts of ptosis, insurance related, you can't see well. All they want is their eye more open. But those very cosmetically oriented patients are a little bit different. So the patient population are different. Where you do it geographically is different. There are places in Europe that don't even do it from the inside, that the training for it doesn't exist. Okay. They only do it from the outside.
Okay. Well, what would make a patient, like, I mean, first of all, how do you diagnose it when they come in? I mean, that you would definitely give them a diagnosis of ptosis.
So one eyelid is lower than the other.
Right. That's pretty easy.
That's the diagnosis. Then the question is, now I've diagnosed it, how am I going to treat it? You have to rule out all the causes I told you, neurologic causes. You could have damage to nerves in the brain and in the orbit, and if there's damage to the nerve, you want to figure that out because it's not important to repair the ptosis. You want to figure out what's causing the nerve damage. Is it a tumor? Diabetes can cause vascular issues that don't allow the nerve to get a blood supply, but then you want to treat the diabetes. So there are medical indications. There is a neurologic condition called myasthenia gravis, where someone gets ptosis and sometimes they get double vision. There's another neurologic condition called Horner syndrome, where that autonomic connection to the eyelid, that fight or flight, that scared response, the nerve gets damaged. In that case, you want a diagnosis. The reason is, if you don't treat the medical condition, which is much more serious than the ptosis is a warning sign that something more serious is going on. So you have to rule out the more serious causes. Once you've done that, and you just identify ptosis, you decide how you want to repair it. And you can repair it, as I said, from the outside or from the inside.
Now, is there something that makes people high risk for this, besides just being older?
Yeah. So when you're doing ptosis, you by definition are opening the vertical opening, the aperture of the eye. If someone has dry eyes, you can make them drier. If someone has a surface irregularity of the eye, by increasing exposure, because you've increased the surface area of the eye that's exposed to the environment, you can worsen that. So you have to rule out surface conditions of the eye, dryness of the eye, tearing, and other things that can be exacerbated. Now, someone may say, I'm willing to have my eyes a bit more dry as long as my eyes are open, I can see better. Right. Or they just may not be a candidate.
Because I wonder, like for myself, I mean, you performed surgery on me. You know, I had LASIK, so I had it 3 times in this eye, 1 in this. I had cataract surgery in both eyes. I had ptosis surgery prior to coming to you to get it corrected. So I would imagine that all of those kind of played in to my ptosis. Now, am I right? Or
so cataract surgery, by putting a speculum in your eye, when they do the surgery, they have to open the eye. You can't. That speculum sometimes can induce a ptosis. Not common, but it can. LASIK surgery also uses a speculum, so it can cause that more significantly. People that have LASIK have a much higher incidence of dry eye. It may rule them out as candidates. It just depends on how significant. But anyone that's had, like I said, surgeries, trauma, other things, it can induce ptosis. You just have to make sure someone's a good candidate. By and large, we mostly see acquired ptosis that I talked about.
Right.
And generally speaking, I'd say 95% of people can have the surgery and have it done well. There's that 5% like there is in everything in life.
Right.
You know, they have that bell-shaped curve or Gaussian curve we learned about as a kid, that like a majority of people are right in the center, then there's outliers on each side. It's the outliers we want to rule out because you don't want to make something worse for them.
I get it.
Yeah.
I get it. So how would somebody, like in middle America, let's say, I think in the metropolitan areas, it might be an easier job to find someone with your expertise. But how would they go about finding somebody like you?
So ptosis, if you want to correct it, basically, if you look up ophthalmology or oculoplastic surgeon, that's an ophthalmologist who did plastics, ptosis is the hallmark of an oculoplastic surgeon. Okay. Because brow lifting, blepharoplasty, fat grafting, fillers, there are other specialties that do. But ptosis, like I said, is really limited, by and large, I'd say 90% of the time, to oculoplastic surgeons. And they exist throughout the country. The society that credentials them probably has 750, 800 members. And there's probably at least double that amount that weren't credentialed but have the training. They just didn't want to go through all the board testing and writing a thesis and all that kind of stuff. So they're out there, and they're in rural communities also.
So if let's say you had a daughter and she had lived somewhere else and had to go to somebody else beside you, what would questions might you tell her or him to add, if you had a son, to ask the physician while they went for consultation?
I would really look at their credentialing beforehand. If they're an oculoplastic surgeon, I'm pretty comfortable with ptosis. It's kind of like a dermatologist that takes molds off. It's probably the most common procedure they do.
Okay.
Yeah.
Because we all have to hope that they get as good a result as I did.
Well, it's also that you're great, so you healed well too.
Anyway, so I so appreciate this because I think this will be helpful to a lot of people. I mean, I must say I was in pharma for 40 years and I didn't know what ptosis was.
Right. And most people don't. They know eyelid surgery to make you look prettier.
Right.
But by the way, ptosis is really important because it makes people look better too, because when they look like this, they like to look more symmetric.
Right. I agree. And especially, I know mine would even get exacerbated when I was tired.
Yep. Which is common.
So I'm very happy with my results, and I hope that people find this of help.
Thank you so much. It was an honor.
All right. Thank you, doctor, for taking time.
All right. You take care.
I appreciate it.
Of course.
If you're interested in contacting Dr. Massry for consultation, I've included his contact info.